That'd be more relaxed, of course. Yeah.
So I'm here at CPHCE 19, which is the Centre for Primary Healthcare and Equity's annual forum. And this is John Fred Levesque, who's the head of the New South Wales Agency for Clinical Innovation, and he's just delivered the keynote about zombies, ghosts and other metaphors in primary care, you know, a bit of a challenging topic. So could you tell us, I guess, you know, an overview, some of your take-home messages from today?
Sure. I think that today's talk and what I really wanted to address was that relationship that we need to have, trying to link theories and conceptual work with very empirical data and, you know, very complex statistics at times. And I am a researcher and a leader in healthcare that is known to be very quantitative. So when I was asked to give the Ian Webster oration, I thought, why don't I try a different angle and try to reflect on how some conceptual work has actually really influenced my statistical work, and how in return doing work that is really quantitative in nature has actually informed some of my thinking around concepts and ultimately some of the publications that I've made. So I've really tried to reflect on some key works that I had the privilege to do in primary care and reflect how, was this showing how theories can really work with data.
So what were some of those experiences that you shared? I mean, particularly you spoke about working in refugee health and your time in Kerala in India.
Yeah, I mean, it all started gradually, really, and I reflect on some of the influences that came along the way and really got me interested in some key frameworks. So, for example, I did talk about a study we did at the refugee clinic in Montreal, where we needed a framework to better understand why refugees were not coming to the practice for some preventive screening. And collectively we looked at the frameworks and decided to do a study around it ultimately, but really it was about structuring our thinking. And I also talked about how the study that I conducted in India as part of my PhD was really a study that revealed for me that we needed to do more around the concept of access and especially inequity in access. And the data that I was collecting was really showing that we had a limited view around that concept, and that's a study that really clearly informed the conceptualization of access that I co-authored with colleagues and has had an impact in research in terms of really structuring the way people are trying to assess access for vulnerable people and especially for people that are combining different vulnerabilities, and that of course makes their journey into healthcare very difficult.
So tell us a little bit about that framework and what has it contributed? Why is it unique?
Yeah, well, this framework really built on previous conceptualization of what access is about. But what it has contributed is that it has put the patient at the center in terms of their healthcare seeking process and all of the steps that they have to go through to ultimately obtain appropriate care from a provider. And the second thing that it has contributed is really to show that access is not just something that depends on the attributes of the practices where people want to go, it also depends on their abilities to interact with those practices. Are they able to identify where they need to go to receive appropriate care? Can they actually go there and reach the services? And once they're in the practice, can they actually get the right care from the provider given their capacity to talk about their symptoms and at times negotiate with providers, about what they need and want. And I really think that that's the second contribution of this framework.
So it's the first time that it's sort of brought all those things together?
As far as I know, it is the first time that all of those elements have been integrated into a single framework that remains relatively simple and therefore has been used in many quality improvement programs as well, and has been tested in many studies.
You talked a lot today about the power of language, and particularly, I suppose, when you were reflecting on your experiences working in places where there are Indigenous populations as well. Could you share a bit about that?
Yes, I've had the privilege of working in Canada, in India, and in Australia in different projects that had to interact with Indigenous populations. And I think that language is important for two main reasons that I want to emphasize today. And the first one is really to ensure that we understand really what's the realities of the people that we want to influence with the interventions that we want to roll out. But also we need to understand how their language is structured so that we create a narrative that will actually help them understand what this is about, and ultimately this promotes acceptance of programs, participation in programs. and really understanding that language is complex, and not assuming that people understand the meaning of words and the way we express is really crucially important, both in research as well as clinical practice and policy practice as well, especially when we work with indigenous populations or people from diverse cultural backgrounds.
So in practice, I mean, this was a bit of a high-level talk this morning. There were a lot of big ideas. In practice, as the director of the ACI, how do you sort of see theory as being important?
Well, the ACI is a very diverse organization with a lot of different programs in many clinical areas, and therefore we do, of course, resort to frameworks and at times also theories to really structure our work. One of the areas where we know that we have to do more is actually to support the building of a better theory of change in healthcare systems. We've got lots of methods, we've got lots of processes that we try to implement. How is this really working? How are the evaluations that we conduct actually contributing to a broader theory that really helps us to understand how systems are changing? Is, I think, a contribution that we can make, but also something that can structure our work as we are tackling more challenging implementation aspects as well. So even for an organization like ACI aimed at really changing clinical care for the purpose of improving patients' health, we can actually resort to frameworks and theories to guide our actions, because it is complicated to try to change very complex systems made of human beings and a lot of moving parts.
You've talked about how we don't often think enough about why things don't work, and we just kind of rush into doing something, looking for a solution without standing back to reflect. How do you see that playing out?
Well, I think in reality it's a bit of an iterative process. We cannot just try to design things perfectly and then try to roll them out. It wouldn't work. We have to get out there and start to work with people. But taking the time sometimes to pause, look at some structuring frameworks really can enable us to identify if there are complete areas that we're missing at the moment or not considering. And these can come from different fields, psychology, sociology, systems thinking. There's lots of people that have tried to look at complex systems, and we can actually import those thinking in our action as we are engaging with people, with clinicians and with teams, and really try to have this as a guide for our action. Because if not, at times we'll forget that there are important elements that may be the key to the success of the intervention we want to implement, and our first thinking maybe was not the right one.
And reflecting on the theme of today, which is integrated care, what are some of the things that are standing in the way of doing this well, do you think?
Well, integrating care is not easy, especially because of what I said here. Healthcare systems are complex, made of many different people, different types of professionals. They're all about that complex interaction between patients and these providers. And we know increasingly now that patients need care that is not solely provided in a single setting. It's not care anymore that is really provided by a single provider even. And very often those patients have got complex health and social and psychological issues that we need to bring together. But bringing all this with very big healthcare systems is a challenge. And many healthcare systems around the world are struggling with this. Can theory, can concepts and model support this? I think so, especially because that topic is very difficult. And I think we can learn from some of the people that have tried really to influence integrated care over the last 25 years and try to learn from what they've done. So it's always part of really trying to build on the shoulders of giants, not reinventing the wheel, but really translating these into concrete applications and really trying to make a difference for patients every day. But this required a structured approach.
You talked about as well the importance of theory in really translating research into conversations with policymakers and decision makers. How do you see that playing out?
I think that as researchers, very often we zone in mostly on our studies and just want to inform the decision makers from the perspective of these single studies, because they're the studies that we know the best. In reality, I think that good knowledge translation needs to put these studies back into a framework so that we can say, this is the contribution of this study that may inform your decision, but there's another field of study that I think is really relevant for your topic or for your question. So again, having a structured way to engage with policymakers is extremely important, because no policymakers want to make an important decision for people and for health system based on very singular and limited studies. So we need to have that capacity as researchers to integrate these, and again, frameworks are fundamental for us to be able to do that in a structured way.
Just finally, you were asked about what the zombies are, the zombies are for you, and you talked about user fees. Can you talk a little bit about that and what that is and why it's a zombie?
Yeah, well, it's really something that comes out of Canada, where I was born, where we really wanted to identify many zombie ideas that were preventing us, we thought, from transforming the system. And some of those zombie ideas are really well entrenched in the, in the way people think about healthcare. So one example is, of course, user fees that are very often heralded as being the solution for overuse of services and potentially waste in emergency department presentations or admission to hospitals. However, the literature is replete with evidence that suggests that user fees unfortunately do have an impact, but they have an impact on people that actually cannot afford to pay, and some of their very meaningful and relevant utilization of healthcare is going to be prevented by this. And ultimately they will need more care because they will postpone or delay health services. And other people that are potentially using discretionary care will not be affected because they can afford that, that user fee. Even though the evidence is replete in the literature, it is still being talked to this day as a way to actually address some of the issues in access to healthcare around the world, regardless of the impact that it can have on equity. And I think that the empirical evidence and some of the knowledge we have about how utilization works and what drives people to use services needs to be mobilized to put that zombie to rest.
Finally, what are some of the equity issues in Australia in your view at present?
Of course there are some issues with outpatient expenditure, out-of-pocket expenditure in Australia. I think there's been many studies demonstrating this, and that plays out not just in primary care, but also with regards to specialized services. Of course, I cannot forget to mention the issues with regards to access for healthcare for Indigenous people that not just face at times financial or geographic barriers to access care, but also at times barriers that relate to cultural aspects and the acceptability of the services that we provide as options for Indigenous populations. And of course these contribute to significant equity issue in Australia, not just in Australia but also in Canada, where I'm from. Similar issues are happening, and certainly addressing those inequities in access to healthcare for the poor, but also for Indigenous populations, should be a priority that we commit to in the coming years.
And what can what can you do from your position, and the people who are here today, what can they do to address this?
Well, working in partnership with local communities I think is key, because if we're to address the various aspects of inequity and access, we cannot just work at the clinic level with the providers. We really need to mobilize the community, because ultimately we need to work on the people's abilities to engage and appropriately access healthcare as well, while at the same time reorganizing the way we deliver care. And this really can only happen through a conversation and a partnership in trying to improve healthcare for these communities.
Coming back to the power of narrative and words.
Absolutely.
Thank you so much for your time.
It was a pleasure. Thank you.